I will be presenting on an article titled Effect of Pre-Hospital Airway Management on Cardiac Arrest Outcomes. Why Our Airway Choices Matter by Jason McMullen, MD, and Justin Benoit, MD. Why our airway choices matter. Endotracheal intubation has been the defining skill of a paramedic. Unlike emergency departments with ample time, space, lighting, and resources, EMS providers are often forced to act immediately and in a less than ideal environment. Out-of-hospital cardiac arrest is the classic case of forced action without time to prepare, and cardiac arrest victims are the most frequent EMS intubations. Recent conversations regarding cardiac arrest have focused on the importance of compression rate and depth, adequate recoil, perishock pauses, CPR density, pit crew modeling, mechanical compression devices, and termination of resuscitation rules. The American Heart Association even restructured the resuscitation alphabet ABCs to put C, which stands for compressions, before A, which stands for airway, all in the best interest of the patient. While paying attention to compressions is of prime importance, the criticality of airway management still remains. Here we have the old way of the ABCs of CPR, where airway came before breathing and circulation or compressions. And here is the new ABCs of CPR, where chest compressions come before opening the airway and checking for breathing of the patient. By the numbers, there are approximately 300,000 cases of out-of-hospital cardiac arrest in the United States every year. 80% will get an advanced pre-hospital airway, 30% will be left at the scene after termination of resuscitation, 33% will get return of spontaneous circulation, ROSC, 25% will get admitted to the hospital, 10% will survive to hospital discharge, 6% will be discharged neurologically intact. There are essentially three options to choose from to manage the patient's airway during out-of-hospital cardiac arrest. There is the back valve mask, which was this one, the supraglottic airway SGA, or which is also called the combi tube, the laryngeal mask airway, the King airway, and the supraglottic airway laryngopharyngeal tube. And there is also the endotracheal intubation. Endotracheal intubation is the most common intervention, but there is growing support for SGAs as first-line airways, particularly to ensure that there are few interruptions and compressions during the early phases of resuscitation. So, like I said, here is the back valve mask, here is the supraglottic airway, and here is the endotracheal intubation tube. The resuscitation outcomes, the consortium experience. The Resuscitation Outcome Consortium, RLC, is a multicity North American research network that has focused on improving out-of-hospital cardiac arrest and trauma care. The RLC pre-hospital resuscitation using an impedance valve and early versus delayed or prime study prospectively enrolled about 10,000 subjects and randomized to early versus late rhythm analysis and real versus sham impedance threshold device. While RLC Prime doesn't directly address the role of pre-hospital airway management, the robust nature of the study allowed investigators to perform a secondary analysis of the data. In the secondary analysis, 8,487 patients who underwent ETI were compared to 1,968 patients who had an SGA placed. Neurologically intact survival to hospital discharge was higher in those with ETI than those with an SGA. After adjusting for many factors such as age, initial rhythm, and bystander CPR, the odds of survival were better with those with an ETI. The odds for ROSC and 24-hour survival were also higher for patients with ETI. Results persisted when patients with unsuccessful airway maneuvers were excluded. In this group of patients, there's a small but meaningful difference in outcomes based on how paramedics managed the patient's airway. The resuscitation outcomes, the Japanese experience. In the All Japan Eustaine Registry, almost 650,000 patients' records from a 6-year period were analyzed, and they concluded that BVM ventilation was associated with a 2.6 times greater chance of neurologically intact survival when compared to ETI or SGA placement. Advanced life support, including ETI and SGA placement, is a relatively new skill. In fact, in this analysis, only 6% underwent ETI and 57% were managed with BVM alone. This sharply contrasts with common practices in the United States. Additionally, approximately 18% of included cases suffered a traumatic arrest, and these patients are expected to have dismal outcomes regardless of EMS interventions. This analysis observed a low overall neurologically intact survival rate of 2.1%, which is approximately 3 times lower than in the U.S. There have been other factors involved that alter the potential benefits of an airway procedure. Here are some of the Japanese paramedics applying compressions to a mannequin. The cardiac arrest registry to enhance survival experience. The cardiac arrest registry to enhance survival, or CARES, was created in 2004 as a collaboration between Emory University, the Centers for Disease Control and Prevention, and the American Heart Association. Similar to the Japanese registry, CARES allows insight into the broad practice of cardiac arrest resuscitation and presents an opportunity to explore the relationship between pre-hospital airway management and outcomes in the U.S. Patients who did not undergo advanced airway placement had better neurologic outcomes than those who received ETI or SGA. So here are showing the survivors where the patients that received a BVM had the greatest survivors, and the patients that received an SGA had the least survivors. Association doesn't equal causation. There are unmeasured and unmeasurable factors that influence both the airway decision and the patient's outcome, no matter how hard EMS providers try to control them, which is why a causal relationship is difficult to determine. A common mistake in interpreting these results is confusing association and causation. Association means that two things are related in some way or are often found together, whereas causation implies a definite cause and effect relationship. So if an EMS provider tries their best to provide the service to a patient and the patient does not survive, they should not confuse what their service to them causing themselves of the patient's death, or blaming themselves of the patient's death. Do no harm and do no harm. Treatment priorities are established as soon as the first rescuer reaches a patient in cardiac arrest, and each decision should be done to maximize the chance of neurologically intact survival. Uninterpreted chest compressions are absolutely essential, and rapid treatment of shockable rhythms is arguably the highest of all priorities. So here are some paramedics. They are in an ambulance, and one paramedic is applying compressions to a patient, while the others make sure that their vital signs continue the same to keep the patient alive. And here are a couple paramedics carrying a patient in cardiac arrest to an ambulance, and here is a symbol showing compressions. Your choice matters. These three studies all show that pre-hospital airway management is significantly associated with neurologic outcomes. EMS providers are recommended to practice BVM, ventilation, and other airway skills. The use of feedback devices help to avoid hyperventilation in patients. Capnography is the best method to prevent this. Capnography is the monitoring of the concentration or partial pressure of carbon dioxide in the respiratory gases, such as giving a patient oxygen to maintain their survival. EMS providers must pay attention to their crew's approach to airway management. Even a single successful attempt may harm the patient in the long run if compressions are interrupted or hypoxia time is prolonged. So the paramedics must continue the compressions unless advanced care can be applied to the patient. Here are forms of capnography to give the patient oxygen. Here is a face mask that the patient puts on their face, over their mouth and their nose, where they receive oxygen. And here is a nasal cannula where the patient receives oxygen as well through the tubes. In the bottom line, EMS airway management will always be a critical component of cardiac arrest management. No matter which ventilation method is used, EMS providers must monitor the effect and guide their team to provide effective ventilations, just as they guide them for effective compressions. So here again are the ABCs or the CABs of CPR, showing compressions, which should be applied first to the patient, airway, opening the airway of the patient to allow oxygen, and breathing, to check for breathing or give breaths to the patient. And here are a couple paramedics giving a patient compressions and oxygen through a airbag mask. And here are some paramedics strapping a patient to bring him to the to take him to an ambulance for further care. And here is my works cited page and the articles information.